Hey guys, how are you all? Welcome back to MedSteps YouTube channel. So today in this video we are discussing about very high yield topic and very important topic for our orthopedic department and in clinical rotation also, and mostly we can see this type of pathological condition in everywhere and in our family members also. Wherever you are seeing about orthopedic problem in knee pain, we have to suspect osteoarthritis. So this is our topic today, that is osteoarthritis. So in this video we are going to discuss little like anatomy and pathophysiology, clinical features, how we can diagnosis and what management and what are the strategies we have to use. And in management we can divide into two types, like non-pharmacological management and pharmacological management, regimens, surgical methods, everything we are going to cover in this video. Okay, so first of all, what is osteoarthritis? Osteoarthritis is a chronic progressive degenerative joint disease. Okay, and it's characterized by the breakdown and loss of articular hyaline cartilage, accompanied by changes in the subchondral bone and sometimes like formation of osteophytes and mild synovial inflammation, leading to joint pain and stiffness we can see, and reduced mobility and decreasing range of motion and functional impairment. So this everything we can see in osteoarthritis patient. Okay, so now we will discuss little amount of anatomy. Okay, if you are seeing this image, this is lateral view of knee joint, lateral view of knee. Here you can see some muscle like rectus femoris, okay, and or quadratus, or you can see that some bursa and some ligaments and meniscus and cartilage and synovial fluid and synovial membrane and bone. Okay, so here first of all I am going to discuss everything in deep. Okay, every part I am going to discuss. First one, here you can see one meniscus. What's the main important thing of meniscus means? This meniscus will distribute the load. Distribute load means weight absorber, and it will take total weight of your body, and then after it act like cushion. How it will act like cushion, and it will absorb the weight and it will distribute the load and it will absorb shock. Okay, so this is very important. So if any problem, if any patient getting pain mostly in medial or lateral area, then we have to think meniscus injury or meniscus problem. Okay, mostly in osteoarthritis problem we will get this meniscal will get degeneration. Okay, so we will discuss first normal anatomy we are going to discuss, and what are the importance of these structures we are going to discuss now. So we covered meniscus, then after ligament. If you are seeing this ligament, what purpose we are using ligament means, these ligaments and capsules will stabilize the joint, for joint stabilization. Okay, next, if you are seeing this image, this second image, you can see here articular cartilage. So what's the main function of articular cartilage means, this articular cartilage is, you can see hyaline made by hyaline cartilage, and it will do covering of bone ends. Okay, if you are seeing this image, I am highlighting this image, this structure we call articular cartilage. This articular cartilage is mostly, it will covers the bone ends. Okay, and it will provide smooth articulation, that for joint it will provide the smoothness, so that's why we call it provide smooth articulation. Okay, next we can see synovial membrane. You can see here, this is the synovial membrane, this red one, I am highlighting this image. So this is synovial membrane. So the synovial membrane also it lines the joint capsule. It lines joint capsule and it will produce synovial fluid. Okay, synovial fluid for main function is lubrication. Whenever we are moving our knee, like knee extension, knee flexion, that time easily our joint is moving because of synovial fluid, because the synovial fluid will provide lubrication. So where from which, like what structure is producing means that is synovial membrane. Okay, so next one, if you see this image, you can see here this is the part of the bone end. In bone end area you can see some structure that is subchondral bone. The subchondral bone is present layer beneath the cartilage, like below the cartilage you can see subchondral bone, and it will give what purpose, main function is it will give supporting to joint surface. Okay, it will give support to joint surface. So you can see here no normal no synovial inflammation, and meniscus we can see here that is intact, and that in patellar we can see pad, we call that is infrapatellar pad, and we can see some intact cartilage, and we can see healthy subchondral bone. So when it's coming to osteoarthritis knee, we can see here this thing, osteoarthritis is caused by age. Whenever that person is getting old age, then we can see that cartilage will get degeneration, that articular cartilage. So that thing we call osteoarthritis. And sometimes it will happen because of mechanical damage, like post traumatic. If any trauma happened in knee, and it can lead to osteoarthritis. Here we can see sometimes we can see synovial inflammation. Why this synovial inflammation happen means, if any patient have before like mild inflammation, or it's contributes with pain and stiffness, then gradually it will go to osteoarthritis. Okay, stiffness. And we can see some meniscus damage also, because that that meniscus is present above the cartilage. Whenever that cartilage is getting degeneration, then automatically that meniscus will get damaged. And we can see some physical and podolytic cartilage degradation. That means here we can see some chondrocytes. Chondrocytes means like making cartilage things. The chondrocytes will get dysfunction. Because of that dysfunction, it will leads to breakdown of extracellular matrix. Because of that thing, because of the degradation and breakdown of the extracellular matrix, that that cartilage will get degradation. Okay, next one we can see infrapatellar pad, that fibrosis, and we can see inflammation. The patellar pad will get increase and it will get inflammation. Okay, and we can see here some ectopic bone formation. This thing we call osteophytes. Okay, so whenever you have problem with the subchondral bone is getting narrow, and that it will give support to the joint surface. But whenever you are getting too much weight on your knee, then it will compress that subchondral bone and it will forms osteophytes. This whenever you are moving, that because of that osteophytes will form some irritation. Because of that osteophytes, you can see in X-ray sclerosis, hardness of the that end of the bone, and we can see some spurs, bone spurs, also known as osteophytes. Okay, and we can see some subchondral bone remodeling also, that bones that that femoral and the tibial bone and this end parts will get different shapes. Okay, because of growing the bone. Okay, so these are the things we can see in osteoarthritis bone, cartilage degradation of cartilage, and subchondral bone changes like bone spur sclerosis and synovial inflammation because of mild inflammation, and it contributes to pain and stiffness. And we can see in between joint space narrowing, this space will decrease, so that part will call joint space narrowing. Why? If you are seeing this image, this is, we have some synovial fluid here, okay, it look like clear, but if you are seeing this image, you can see here this is joint space narrowing. The joint space will get narrow, okay. And another thing, the bone that reduces space between the bones, okay, joint space will get narrow, and you can see here this cartilage get degradation, okay. And this part, this is the subchondral bone, this will get sclerosis, that means it will get thickness, okay, it will form like hard, so that's why we call this is sclerosis, subchondral bone changes, okay. And here we can see in this area there's some osteophyte formation, and some that part will get different, and that bone will structure will change. Now we are going to discuss risk factors in osteoarthritis. First one, age. Increasing age can cause osteoarthritis, okay, because of that muscle will get weakness, like hamstring, calf muscle, and quadratus muscle, everything will get weakness. Because of that weakness, that joint space narrow will happen, and that because of that too much weight also, that because of that no chondroitin, it will cause that osteoarthritis. So age is the risk factor. And gender, mostly females will affect for osteoarthritis, especially postmenopausal female, because of low estrogen, the patient will get decreasing bone density can cause osteoarthritis. Next one, obesity also can cause osteoarthritis. Why? Because whenever that patient have like too much great BMI, obese, the time that patient we can see increased mechanical load on weight bearing joints, and joints will get too much weight. Because of the too much weight, that patient will get stiffness of the muscles and pain, and stiffness and everything we can see in osteoarthritis patient, okay. This is obesity is the risk factor. So what we have to do, the patient have to reduce the weight. Next, joint injury. If any patient got previous history of injury or trauma or accident, and they are very predisposed to OA, okay. Next one, genetics. In genetics, if patient have family history of osteoarthritis, they are very risk can get osteoarthritis. Next one, occupation, like jobs involving like athletes are repetitive joint stress, always standing doing work, walking doing work, okay. This people is very prone to get osteoarthritis. So these are the risk factors. In risk factors, age, gender, obesity, joint injury, genetics, and occupation, okay. Next one, clinical features. If you are seeing clinical features, we can the patient will tell I am getting pain, okay, and its pain will worsen with activity. The pain will be worsened with activity, and it will relieved by rest. Next, stiffness. The patient will like will complain like less than 30 minutes in the morning, that patient getting more stiffness, okay. And our patient will complains like after activity I am getting too much stiffness, like that the patient will tell. Whenever patient getting stiffness, because the stiffness can cause, because of weakness can cause stiffness, okay. So that's why that patient will tell like I am getting pain, I am getting stiffness, this type of things. Next one, crepitus. Crepitus means crackling sound. Whenever we are flexing the knee, that time we can see crackling sound during joint movement. Okay, that part we call crepitus, and and we can see the reduced range of motion because of due to pain, and some structural changes because of that osteophytes formation. Whenever that patient is moving that knee, automatically that patient will feel pain, and because of that pain, that patient will reduce the range of motion. Okay, like because of structural changes. Next, we can see some joint deformities. If you are seeing this image, if any person getting nodes in distal interphalanges here, in this distal interphalanges, then we call that name is Heberden nodes. Heberden's nodes. If any if patient getting proximal interphalanges in this area, if patient getting proximal interphalanges in this area, then we have to we can call that name is Bouchard's nodes. Bouchard's nodes. Okay, so this is the joint deformities we can see, and we can easily find out the patient have osteoarthritis. Okay, Heberden's nodes and Bouchard nodes. Heberden nodes we can see in distal interphalanges. Bouchard's nodes we can see in proximal interphalanges. Okay, in fingers we can see this thing. Next one, how we can diagnose the osteoarthritis means, first one, clinical evaluation. In clinical evaluation, first we are going to do history, and we have to check about risk factors and everything. Then we have to do some special test. Then after physical examination, in physical examination we have to check that sounds and the crepitance, pain, swelling, redness, warmth, any inflammation, everything we have to check in clinical evaluation. Next one, imaging. If you are seeing image, we can see here in X-ray we can see like joint space narrowing. That joint space will decrease the space, so we call that is joint space narrowing. We can see, you can appreciate this image here. The joint space got narrow. If you compare with this image, like right side image, you can, if you are comparing with right side image, then this left side image you can, that joint space decreased. So this is the first main thing in osteoarthritis. Second one, osteophyte formation. If you are seeing here, some structures is coming out, the structures we call osteophytes. So osteophytes will form. Then after we can see subchondral sclerosis. If you are seeing this image here, you can see like whitening structure. This whitening structure we call sclerosis. Whenever that bone getting hard, then we can see hypoechoic structure in X-ray. So these are, we can interpret it with like whiteness structure like this, then we call that is osteophyte subchondral sclerosis. Okay, and some patients we can see cysts also. So these are the things we can see in X-ray imaging. Okay, 4 things I told. First one, joint space narrowing, osteophyte formation, subchondral sclerosis, and cysts. Okay, and we have in osteoarthritis we have some grades. So how we can give that grade means with X-ray only. We have one classification how to find out the grade. We have one classification. Now we are going to discuss that classification. The classification name is Kellgren and Lawrence grading. Total we have 5 grades. In 5 grades, first one, grade 0. In grade 0 we can see no radiographic features. So we can't see any in X-ray. No, we can't see any radiographic features. Okay, when it's coming to grade 1, the joint space narrowing we can see like 4 to 5 mm, and we can see some osteophyte lipping like less than 1 mm. In grade 2, that possible joint space narrowing like less than 4 mm, and small osteophytes we can see like 1 to 2 mm. In grade 3, joint space narrowing we can see like 3 to 4 mm, and moderate multiple osteophytes we can see like less than 3 mm, and we can see some deformity of bone ends, and we can see some sclerosis. When it's coming to grade 4, we can see like severe joint space narrowing less than 2 mm, or complete loss, or we can see like large osteophyte greater than 4 mm, and we can see like definite bone deformity and marked sclerosis. Okay, you can see here this image and you can compare. This is the osteophytes. Okay, and you can see bone remodeling also we can see here, and the joint space will decrease, so joint space narrowing, and we can see some integrity means subchondral bone got sclerosis, that part we call irregular structures. Okay, and the osteophytes and this everything, and tibial spiking, these things, this everything we can see in imaging of X-ray imaging of osteoarthritis. And we can do MRI. MRI if you are suspecting like detailed assessment of cartilage, and if you are like any soft tissue damage or ligament damage, that time we can do MRI. And if you are suspecting about rheumatoid arthritis, then we can do like we can do like rheumatoid factors and some laboratory tests. Okay, so if you are suspecting rheumatoid arthritis, then only. So next, management. Now we are going to discuss some management. This management I divided into two types, like non-pharmacological and pharmacological. First we are going to discuss about non-pharmacological. In non-pharmacological, first of all we have to give education to patient, because the patient have to know about totally about osteoarthritis and regimens, everything. So first we have to counsel the patient. Okay, so we have to inform, or we can counseling about osteoarthritis. Okay, second one, that we can prescribe some exercise like low impact aerobic activities. Okay, next one, strengthening, and next flexibility exercises. Okay, next one, we can do weight management, like we have to convey the patient have to reducing weight, because it can decrease the joint load on knee. Okay, then after we can tell to the patient to start physiotherapy to improve the joint function, and we can we can prescribe some, we can tell some supportive devices also, like canes and braces, or orthotics to support the joint. So these are the this everything will comes in non-pharmacological management. When it's coming to pharmacological management, first regimen will be like, first of all, that if the patient telling like I'm getting mild to moderate pain, means then we have to start with acetaminophen like paracetamol or Panadol. Okay, so how much dosage? 500 to 1 gram every 6 hours, maximum 4 grams per day. If patient have any liver function problems or liver disease, liver cirrhosis, then it's very it will cause some complications in liver, so that's why we have to change the medication. Okay, next one, analgesics. Next one NSAIDs. In NSAIDs, like non-steroidal anti-inflammatory drugs, if patient telling like moderate to severe pain, then if we are suspecting any inflammation, then we have to start NSAIDs. In NSAIDs we have different options, like first one, ibuprofen. We can give like 400 to 800 milligram every 6 to 8 hours. Maximum dose will be 3200 milligram per day. Or naproxen also you can use like 250 to 500 milligram BID, like maximum dosage will be 1500 milligram per day. And you can use like diclofenac 50 milligram BID, like TID, or maximum dosage will be 150 milligram per day. Okay, next one, in duration, if we can use the lowest effective dose for the shortest duration, and we have to observe and we have to monitor the we have to monitor for side effects, like assessing for gastrointestinal or renal and cardiovascular side effects. Okay, next one, in topical NSAIDs we can use if you are suspecting like localized osteoarthritis, especially in knee and hands, then we can start like diclogel. Okay, like 1% per day 4 times the patient have to apply, and we can use up to like 12 weeks. Okay, and we can reassess and efficacy. And in advantages, one advantage we have, that is lower systemic absorption, and it reduces the risk of systemic side effects. Next one, duloxetine. In duloxetine, if you are suspecting chronic musculoskeletal pain or including like osteoarthritis, then we can start with 30 milligram once daily, and we can increase to 60 milligram per day also. Okay, in duration we have to evaluate response after 4 weeks, and if it's after 4 weeks, if it's beneficial, then we can continue this medication. And we have to always monitor like side effects like nausea, dry mouth, and what it can dry mouth, and it can cause fatigue also. So we have to observe side effects. Okay, next, after these medications, if still if you are feeling getting like pain and this thing, then we can go with intra-articular injections like corticosteroids. If patient like acute exacerbations with joint infusion, then we can start with this corticosteroids, that in agents like triamcinolone acetonide, like 20 to 40 milligram per injection we can give. Like that frequency will be every 3 months, and that limit will be 3 to 4 times per year. Okay, next we can start hyaluronic acid. Like indications will be like knee osteoarthritis, unresponsive to this conservative management and everything, then we can start hyaluronic acid. Like if knee osteoarthritis is with that other treatment is not working, then we have to start hyaluronic acid. That regimen will be like weekly injections for 3 to 5 weeks. That efficacy will be like variable, some patients report symptom relief also. Okay, and yeah, we can give like some supplements like glucosamine and chondroitin and turmeric and vitamin E, vitamin C and vitamin D. Okay, these are the supplements we can give for decreasing this osteoarthritis and getting that cartilage formation. Okay, and we can do PRP also, like plasma rich protein. That means they are extract that physician will extract some blood for us, then after they will keep in one mission, and that it will divide the plasma and erythrocytes. So that plasma they will insert into the inside the knee. Okay, it will help, and it's very beneficial. We can use that things also. I didn't mention here, I'm really sorry, but I explained this thing. Next, opioids. If patient getting severe pain and that unresponsive to that conservative management, then we can start with tramadol. In tramadol, 15 to 100 milligram every 4 to 6 hours. Maximum dosage will be like 400 milligram per day. And this tramadol will be like short term use only, because it can cause too much dosing. Okay, so that's why nighttime will be this nighttime taking medication is very good for tramadol. Okay, in note, long term opioid use is generally discouraged due to risks. Okay, next one, surgical interventions. In surgical interventions, first one, if patient getting like functional impairment, unresponsive to conservative management, then we have to do conservative surgical interventions. Like first one, arthroscopy. In arthroscopy, if patient like getting like limited role, may be like beneficial for mechanical symptoms. Next, osteotomy, realignment procedures for younger patients with unilateral osteoarthritis. Next one, joint replacement. The joint replacement, like total or partial replacement of the affected joint, effective for end stage and of osteoarthritis. Okay, for follow up, we have to do regular assessment, and we have to evaluate the pain levels and joint function and quality of life. and we have to check like medication review and monitor for efficacy and side effects, and lifestyle modification like encourage adherence to exercise and weight management plans, and we have to do imaging like repeat only if clinical status changes or to plan surgical interventions. That time we have to do this imaging. Okay, in summary, the diagnosis will be primary clinical evaluation like physical history taking and physical examination, then after imaging, and imaging will be like for confirm the diagnosis and supportive assessment. In management, start with non-pharmacological strategies, then after we have to go with medication as needed as supplements. Next, pharmacotherapy used with the lowest effective doses, and we have to always monitor for side effects. Then after surgery, if that consider like when conservative management measures fail, then we have to go with surgery. And patient education is very important to the patient. Okay, so I covered everything like anatomy, pathophysiology, risk factors, clinical features, and diagnosis, management, and surgical interventions. Everything I covered in this video. Like if you have any doubts, you can ask me in comment section. And here main points will be like if for osteoarthritis, cartilage degeneration, and subchondral bone sclerosis, osteophyte formation, these are the things very important. Okay, so I covered everything. If this video is very helpful for you, like, share and subscribe. If you have any doubts, you can ask me in comment section. Take care, bye bye.